Hi.
How are you?
Good. How about you?
Good.
All righty, we are recording. Okay, is everybody ready?
Yes.
Inflammation. Here again, we have a, oh, there's Fernando. How you doing? Trying to get my
morning.
Show small active speaker. There we go. Okay. Today we're going to talk about inflammation. It's another nursing concept. Ba-dump. I love that guy. Anyway, what we're going to do is we're going to talk about inflammation, the nursing concept of inflammation, and then we're going to talk about 3 pathophysiologies to go with that nursing concept. It's going to be rheumatoid arthritis, osteoarthritis, and gout. I'm reading a book right now on pirates, and evidently gout was a real problem with people from Europe coming to the tropics. I'm not sure why that was. I'm going to have to look at that further. All right, here we have this guy right here. If you see him on the slide, you may want to remember that. Hint, hint. Anyway, getting on with it. Here we have inflammation. It's the body's protective response to injury, allergens, or infections. And we all know, we're all familiar with inflammation. That's when it swells up, gets red, hot, etc. That's your body's reaction to an injury or an infection. Now we're going to talk about infection in part B this afternoon at 11 o'clock. So we're mostly going to just talk about injury right now. The purpose of inflammation is to eliminate the pathogens that are infecting the area or rushing blood and resources to the location to help heal the injury. For example, when you sprain your ankle and your ankle swells up, that's an inflammation. There's no pathogen or infection going on. It's just your body's reaction to try to help heal the area. Things that you want to do as a nurse, you want to identify patients that are at risk of inflammation and provide treatment for those inflammatory responses. It could be a variety of things: medical, anti-inflammatories, the old RICE acronym: rest, ice, compression, elevation, etc. Let's dive into the very first one. This is a real nasty one: rheumatoid arthritis. I'm sure many of us have met people with this condition. This is an autoimmune disease. Basically, what happens is your body attacks itself, causing the inflammation. They had for a long time, they thought it might have been related to staphylococcus infection. And what they thought was the staphylococcus was very similar in DNA structure to what your joint cartilage was like. So as your body launched its immune system and tried to kill the Staphylococcus aureus bacteria, it actually mistaked the cartilage for the bacteria and attacked the cartilage as well. I don't think that's the predominant thought today. I haven't seen that lately. And basically all I've seen in relationship to RA is that they don't know why the body does it, but your immune system attacks the cartilage in your joints and destroys them. And that is what causes an inflammatory response, resulting in the swelling, the aching, and the pain in the joints, and eventually the degradation of the joint itself. We don't know really what causes it. We don't really have an effective treatment for it either. It's pretty much palliatory on the treatments. Although we do have some drugs out there that kind of help slow that process down. One of them you've been hearing a lot from President Trump, the hydroxyquinine drug that they're touting might be good for COVID-19 is a drug that's also used for RA and used for lupus. In fact, that's its main purpose. In fact, they're worried right now that because of the COVID-19, the RA victims and the lupus victims are not getting an adequate supply of this drug. Here's different stages of the rheumatoid arthritis. Stage 1, the body mistakenly attacks the joint tissue, thinking it's a pathogen. And then as the antibodies build up in that joint, we have inflammation. And that inflammation causes a swelling at the joint. It eventually becomes bent and deformed. And we've all, as I showed you the pictures up here, you see how the fingers of the hand seem to go off at an angle. That is typical of the damage that RA causes. And it hits the fingers and the legs. Joints become bent and deformed. This causes severe impingement upon the nerves, which causes severe pain. It's an extremely painful condition. And my heart really goes out to people with RA because there's really not much we can do about it. And it's almost like cancer in the sense it just kind of eats you up. And we can slow it down, but we can't stop it. What you will see, usually the first signs and symptoms of rheumatoid arthritis are not actually the joint pain, but you get a fatigue, a malaise, and low-grade fever. Now, you will notice this is very similar to, say, the flu. Well, your flu symptoms are your body launching an immune response. So the same is true of RA. Your body is launching an immune response. So the signs and symptoms are going to be similar to what they would be with the flu. Labs, there is a test where we test for RA factor. And although an elevated RA factor may not necessarily mean you have RA, but in 75 to 80% of the patients who have RA, we find the RA factor is elevated. So if you're having the signs and symptoms of RA and your RA factor is elevated, it's probably a pretty concise diagnosis that you have RA. X-rays are late in the diagnostic cycle. I mean, those only show up after the joint has become deformed. Oh, there he is. Something on there you might want to remember. I think it's probably the first one. Medical management, NSAIDs for the inflammation. There again, you know, what I mostly found, and this is just personal experience, as far as Tylenol goes, Tylenol is good for headaches and possibly some joint pains as such, not real good for inflammation. Anti-inflammatories like ibuprofen work much better on inflammation, swelling, joint pain, etc. Thing about Tylenol is it impacts the liver. Thing about ibuprofen is it impacts the kidneys. So just for your own personal information, you might, you know, you'll want to know that for the future. If somebody comes in for dialysis, their kidneys are failing, they'll probably be on Tylenol, but they will not be allowed to have ibuprofen. So just remember that. You're not being tested on it, but just remember, Tylenol impacts the liver, ibuprofen impacts the kidneys. You probably got all that in your pharmacology class. Corticosteroids. Corticosteroids are the best anti-inflammatory medicine we have to date. Unfortunately, corticosteroids, we're talking about things like prednisone, solumedrol, have a lot of bad side effects to them. But they're the best thing we got for severe inflammation. If you take them for a short period of time, you know, a month or two, that's okay. But people who end up on them, you know, for life, they have a lot of bad side effects to them. DMARDs, disease-modifying anti-rheumatic drugs, DMARDs. I don't know, did you guys study these at all in pharmacology?
I don't remember that we did.
Okay.
I don't believe so.
Okay. I don't know if you will because they're kind of a specialty, but what they are is an immunosuppressant drug. For example, when somebody has a kidney transplant or whatever, and they give them immunosuppressant drugs to keep their body from rejecting that organ. Immunosuppressant drugs, what's doing is your body is launching an immune response against your joints. So if we can suppress the immune response, it won't attack the joints as much. So that's the whole purpose behind an immunosuppressant drug. The bad thing is when you suppress your immune system, you're opening your body up for other types of infections, which is why people with transplants always have to be very careful about not getting sick. Nursing management, couple nursing diagnoses you might see with RA, of course, is pain. And that's probably going to be chronic pain. NSAIDs for pain, other medications, impaired mobility, of course. Joints become very painful, hard to use. Physical therapy, you know, I personally don't know if exercise helps with RA. It does with osteoarthritis, which we'll look at next, but I'm not sure how physical therapy works with RA. But you do want to keep those joints moving. And nutritional
It helps
deficit.
minimally.
Pardon?
It helps minimally.
Minimally? Okay.
It reminds you to keep moving and in proper body mechanics. But like, as far as pain goes, I wouldn't say it helps diminish pain.
Yeah. With osteoarthritis, exercise can actually improve the joint. I don't think that's the case with RA, but yeah, you have to keep moving. The more immobile you are, you know, the more the joint, you just have to keep what little fluid you got going in there going. Yeah. Malnutrition is very common in rheumatoid arthritis, psychological reasons. It's just painful to move, to fix meals, etc. You got to make sure that people stay up on their nutrition. Okay. Any questions on rheumatoid arthritis before we move on?
No.
Nope. Nope.
So
Got it down pat.
Have what? Rheumatoid arthritis is not treatable, correct?
We can't treat the cause because we really, frankly, don't know what the cause is. So there's no cure. So what we're doing is we're treating the symptoms.
Symptoms, correct. Yeah.
Palliative care. Yeah.
All right. Thank you.
And some of the DMARDs slow down the progression of the disease. So that's the best we can hope for.
I'm going to
Okay.
sound like a broken record, but just so you guys remember that stuff like rheumatoid arthritis, type 1 diabetes, and Crohn's disease, all kind of come from the same place. You get a bad inflammation or infection, and then a couple months later, sometimes these diseases pop up.
Good.
That's it.
Chime in any time, Eileen. You got a wealth of experience, and I would love to take advantage of it.
No, that's all right. My microphone's not that great, so I see everyone put their head on the on their keyboard
Yeah.
when I talk.
I used to have a saying when I was back in nursing, and it said the best way to become an expert in a disease is to contract it. Because someone would come down with something, and boy, they would research it ad nauseum and become a real expert in it, as I'm sure any of us would if we contracted something. So, moving on. Osteoarthritis. Here's one that's near and dear to my heart. Osteoarthritis is also called degenerative joint disease, or DJD. Basically, that's just where you wear the joint out. After years of running and hiking and weightlifting and all kinds of bizarre crap I used to do, I pretty much wore out the joints in my knees. So they sound like a well-known breakfast cereal every morning. So factors that go into creating osteoarthritis are age. We used to call in the ER TMB, too many birthdays. Injury, obesity, of course, for the weight on the joints, and genetics. Paget's disease is one that leads to osteoarthritis. These are all contributing factors. Oh, might want to remember that first one there. Moving on. Here's the example of a degenerated joint. Basically, you'll notice as you've probably seen in other slides, there's a bursa down here that contains synovial fluid. That's usually eroded, it's flattened out, it's lost its fluid. It may even totally degenerate to the point where you actually have bone on bone. And these osteophytes right here, better known as bone spurs, can develop. Basically, it's just a joint wearing out. Assessment, you'll get stiffness, pain, irritation, crepitus. Crepitus, we all know what crepitus is. That's when the joint moves and you hear crunch, crackle, crinkle, crack. That's called crepitus. Some people get severe arthritis, especially the hands. They'll get Heberdine's nodes and Bouchard's nodes in the hand. See this on older people. They'll just have big, their knuckles will be enlarged. That's what it looks like. Best way, X-ray is our most common diagnostic facility because it just shows that cartilage gone and the bones are just kind of plump on each other. Management, there again, NSAIDs, anti-inflammatory medications. There again, when you're giving somebody NSAIDs, you have to watch out for liver and kidney function. I used to take ibuprofen, and then my doctor said, stop taking the ibuprofen because it impacts the kidney. He told my wife the same thing. So without ibuprofen, it kind of limits your possibilities. Heat and rest, of course. Heat always feels real good on an arthritic joint. Exercise. That is the most important thing right there. You have to keep exercising. My dad has severe arthritis of the hands, so he took up gardening. And gardening just keeps the joints moving. The more you move the joints, the more fluid that is produced to help lubricate that joint. And although it's painful sometimes to get those joints moving, they feel much better afterwards. And it arrests the long-term effects of the arthritis.
Bryce, I had a question.
Yeah.
How about naproxen for treating this?
Naproxen is good. Eileen, you might be able to help me out with that one. Is that the same family as ibuprofen?
Yeah, it's an NSAID, and then it just doesn't, you don't have to take it as much. You only take about twice a day or so, but it's an NSAID.
Yeah,
Okay.
I think it's under the same category as ibuprofen, though, in the sense that it impacts most drugs will either filter through your kidneys,
Right.
Mm-hmm.
they're water soluble, or they will filter through your liver if they're oil soluble or fat soluble. So I believe that's one that goes through your kidneys.
Right.
Yeah.
Okay, thank you.
You're welcome. Some alternative medications. The one that comes to mind, of course, is the cannabis extracts, the cannabinoids. These can be taken oral. They can also be in the form of a lotion or a salve that can be applied to the joint. I have used the CBD salve on my knee joints before and had some pretty good results with that. This is really a good possibility here because it doesn't have the impact on your kidneys or liver that some of the other medications have. Other alternative medications, I've had really good luck with chondroitin and MSM. Those seems to, that is a natural a natural supplement that's supposed to help with the lubrication of the joints. I've had pretty good luck with it myself. So trying everything alternative I can to get away from ibuprofen. And of course, ultimately there's joint replacements, which I think we kind of looked at in the last lecture. There's something there you might want to remember. I think it's this one. We'll see. Nursing management. Of course, chronic pain, medication, education on heat, rest, impaired mobility, exercise. There's also problems with activities of daily living. So there are devices that will assist with that. I think it's on this slide. Self-care deficit, here we go. Assisted devices, instruction on self-care. Here are some devices that can be used for people with arthritis. The device, this one here is good for opening doors and taking the lids off bottles and cans and stuff. It's hard to grab smaller items when your hands are arthritic. So anything with a bigger grip, like the silverware, it just has a much bigger grip. It's easier to grab. This device here is used for putting socks on. Shoe horns with the long handle on them is also good for helping you put shoes on. And there are a variety of assistive devices out there to help people with their arthritic conditions. Before we go on to gout, is there any questions on osteoarthritis? I think I'm doing good for time, trying to keep these down to about a half hour, so we're doing good.
I have a question.
Sure.
What do you, when my mother, I think she had arthritis, the doctor injected some sort of fluid in her knees. What are those?
There's a couple things going right now. One of those is hyaluronic acid. Hyaluronic acid has been used for years in the horse world. In fact, we used to call the liquid legend. And we take legend and inject it into the hocks of horses. Hocks are their lower ankle. Horses' legs are really delicate. I'm really amazed after having horses how fragile horses really are. You know, from the Western movies, you think they're all these tough, hardy animals. They're really not. But we would inject that hyaluronic acid into the joint. It helps the joint to lubricate. Some cowboys actually started pouring legend in their coffee, and they found it helped their joints. And it's more recently been approved for human trials. So they will take and inject that in. There's also a process whereby they will take fluid from your body, your plasma, and they spin it down, they get the DNA, and they use that to create a fluid. It's almost like an artificial joint, but not quite. And this is where the DNA manipulation comes in. And Eileen, you might be able to help me out on that. But basically, they create a fluid using your actual DNA so that your body doesn't reject it. And then they shoot that into the joint also to kind of help create a padding in the joint. And it's pretty new and experimental, but I've talked to a couple people who've had pretty good luck with it. It's not like an artificial joint though, because it only lasts for like 6 months or so, and then you have to redo it. We did do that with some of our horses also. We had barrel racing horses, and you do everything you can to kind of keep those joints going until, you know, the horses wore out. You can't use them anymore.
Yeah.
Eileen, have you heard about that?
Yeah, I've heard about it, but I've never studied it. I've never studied any of that, so I don't know too much about it, but I've been hearing more about it.
I've heard about it. You know, like I said, we use it a lot on our horses, but then it's only recently migrated from the veterinary world over into the human world, you know, because they have to go through all these trials and everything for humans that they don't have to go through for animals. So we've been using it for years on horses, and it's just now making its way to humans. But it does involve drawing blood from the person, spinning it down, and using that DNA to grow a culture that then gets injected back into the joint. And I'd have to look closer at it to see exactly what that's all about. But for years, we've been using the hyaluronic acid injections. And there's also steroid injections into the knees. By injecting a corticosteroid directly into the joint, it helps reduce the inflammation of that joint. Because I know,
That's probably what we did.
yeah, for years, people have been getting steroid injections into their joints. That's an old common practice.
My mom gets the injection every 6 months. So, and that's why I was asking the doctor, like, is it just to relieve the pain or it's really treating it? So, but they said like, it's just really to relieve the pain. So,
Yeah.
okay.
The good thing about steroid injections is they only impact the area where you put the injection. So they're not affecting your entire body. You get less of the bad side effects from the corticosteroid. And I've seen a lot of people get the injections into their back. Some people get it in their knees. Those are the two most common places I've seen it.
Thank you.
You're welcome. Let's move on to gout. Gout. Gout is a very painful inflammation of the joint, and that inflammation is caused by the accumulation of uric acid crystals in the joint. Uric acid is one of our byproducts of our metabolism. We normally urinate those out, but the uric acid can accumulate in a joint and form crystals, and these crystals make the joint extremely painful. Most often occurs in males over 30 years old. When I was hiking on the PCT, my hiking partner had gout, and every once in a while it would flare up in his right foot, and it really made him miserable. So I got to see it firsthand there. Risk factors include diabetes, obesity, hypertension, and leukemia. All these predispose a person to the possibility of contracting gout. Other things that aggravate it, though, and this is the trouble that Perry had with his, is he wasn't a coffee drinker, but he did drink alcohol, and alcohol will lend to dehydration. Dehydration can aggravate gout. And also foods that are high in purine. And it's mostly seafood, especially shellfish, that are really high in purine. So if somebody has gout, they have to avoid the seafood and stay hydrated. That's two things to remember about gout: is stay hydrated and avoid the seafood. Oh, look, that guy popped up again. Assessment. Woo, wow, look at that finger. X-ray is usually the most predominant method for assessing, as it'll show the inflammation within the joint, and a uric acid test. There's two different forms of measurement for the uric acid. The other one will be in the 400 to 500 range. I can't remember what that was. It just depends on what type, how they're measuring the test. The milligrams per liter, if you're greater than 7 milligrams per liter, it's usually indicative that your uric acid levels are high. There again, if your uric acid levels are high, you may not have gout, but if you're having joint pain and swelling and your uric acid is high, it's probably a good indication that what you're suffering from is gout. The most concise one is to actually insert a needle into the joint, aspirate the fluid, and test for uric acid crystals. How to management, there again, the NSAIDs for swelling. Colchicine is the most common medication I've seen prescribed for gout. And colchicine helps to break down those uric acid crystals in the joints and get them in your bloodstream, and hopefully you just urinate them out. Nutrition, again, avoiding seafood, staying hydrated, and surgery. They can actually go in and work on the joint surgically if they have to. I like that picture. It's pretty cool. Nursing management, impaired mobility. More often than not, it hits the foot. Toes, big toe in the foot is a real common place for gout to strike. when gout does strike, that toe is extremely sensitive. So a bed cradle, which is this wire hoop that goes over the end of your bed, you've probably seen them before. It keeps the sheets and the blankets off of your feet because the weight of the blankets on your toe is excruciating. Hot packs or cold packs, depending on the patient's preference, whichever helps it feel better. Pain, medications, NSAIDs, colchicine. Colchicine will help with the pain. It helps get the uric acid crystals out, but it'll also provide some relief to the patient.
Bryce, I had a question. You said it mostly affects the feet. Is that because of gravity with the crystals?
Oh, I know that one.
Okay.
Because it goes, it seems to settle in the coolest parts of your body. So, you know, your toes and your fingers are going to get it because they're cooler than inside, you know, than your arms or your shoulders or your hips. Yeah, so that's why. So yeah, it's usually the coolest part of your body, gout will settle in.
Oh, okay.
Would that be because the coolest part of your body has the most limited circulation?
Oh yeah, I think that's it. Yeah. So if your arm is really cold, you're going to get gout all over there. But that's why gout seems to thrive in coolness or in the cool, and you're going to see it like in your shoulders or your hips, unless you're, you know, a cold person.
Okay.
I'm in trouble
Thank
then.
you.
My feet are always cold.
Well, there you go. Look for that gout.
Yeah, and that would also explain why people like with diabetes are at high risk because they're already getting compromised circulation from nephropathy.
Right.
And their kidneys are not processing properly, so they may not be eliminating uric acid as well as other people may be.
Yeah, I think you're right there.
Last nursing diagnosis would be knowledge deficit. You really have to work with these people to watch their diet, watch their hydration, but also be sure that they get in to get their lab tests done, especially on the uric acid. It's the only way to make sure that their colchicine and that their gout medications are working effectively. Any questions on gout? All righty. Boom, we're done. Any more questions? I'm going to turn off the recording then.